recommendations in this area, we recognize that there's good public health reasons to take care of people at home, which is where most people want to be taken care of if they have a choice. And there's also civil rights reasons for doing that, so people can have full lives in the community and be integrated with their family and friends. So I just put that out there as more for us to develop as we move forward.
Very important flag. Thank you very much, Mr. Imparato. Anyone else? Okay, wonderful. Congratulations again to the Healthcare Access and Quality Subcommittee. Another job very well done. Dr. Okafor, please.
Thank you, Madam Chair, and thank you to exceptional job, really, done by our Health Care Access and Quality Subcommittee. It is a great joy for me to introduce the next subcommittee, and that will be our Structural Drivers and Xenophobia Subcommittee. They have done exceptional job as well, and I would like to introduce the chair to step in and begin to present the more detail of the work that they have done. So I'll call upon Ms. Heyang, to come in and share with us the outstanding work that the Structural Drivers and Xenophobia did. Thank you.
Thank you, Dr. Okafor. Can we go to the slide that has a list of members of the subcommittee? I want to also echo the much appreciation for the members of the structural drivers for really thinking through robustly the needs of our community. As I agree with Mary Turner that we're very much going through the pandemic, but also really thinking ahead about how do we make sure that we protect all of our families and communities across the country for any future pandemics. So deep gratitude again for Myra Alvarez was not able to join us because she's on her parental leave. But it's the members who participate in this month's conversation is Sarah Bleich, Jessica Cartachone, Richard Cho, Jamila Gleason, Jolinda Johnson, Victor Joseph, Octavio Martinez, Shannon Pauser, Mary Turner, and Bobby Watts. And deep appreciation for the staff to guiding us through this conversation. Can we go to the next slide? So this month for the thinking about what are the systems and practice we really need to be thinking about as we look ahead for being better prepared for future pandemics, we have 5 problem statements. Can we actually go to the slide where that has the recommendation? I want to go through both the problem statement and the recommendations using those slides. Thank you. So the first one is really looking at, we've been talking about the need for robust safety nets to make sure that all communities across the country, states, and tribal nations have the basic needs to really thrive, be safe, and be protected. So we come back to to underscore that point that the pandemic has really underscored the need for robust safety nets, right? That's ranging from food, transportation, housing, education, income support, and the care for our families and communities, whether that's childcare, as Andy Imparato talked about in terms of making sure that people with disabilities or older adults have the long-term supports and services they need in home and community settings, right? To all these needs, making sure that people have the right kind of travel and lodging stipend to travel to get access to care, right? All these safety nets, we must make sure that that these are needed to protect working families and the most at high-risk populations. I think this pandemic and the programs that are rolled out helped us to learn that these rolling out of programs must be developed and implemented quickly and efficiently. And so moving forward, that all communities have the basic needs, right? And so it's really building upon this COVID-19 response, and for the federal government to use its full executive authority as well as to work with Congress to provide these very much needed safety nets and programs. Can we go to the next slide? So second problem really is looking at the COVID pandemic also exposed inequitable access to clean and natural resources such as water and air and lack of quality control. And then also lack of public utilities such as modern waste management. So we have 3 recommendations to making sure that these that there's a relationship between our climate change and inequitable access to basic things like water and air, resulting in health outcomes, worsening of health outcomes, and especially affecting those who bore the disproportionate impact of the disease itself. So the 3 recommendations we have are instituting a national moratorium on water and utility shutoffs to ensure that there is sanitation efforts and making sure that people are safe, that have access to water and that needs that they have to meet both the kind of the emergency needs, but also just to have their basic needs. Allocate federal funding for grants and funding to cities, states, and tribes, and also funding for technical assistance to replace the household plumbing and lead service lines to advance of a future pandemic, so that we're not repeating the harm that communities were facing through this pandemic. Also establish a permanent low-income utility. So that's water, electricity, waste management assistance program, akin to a low-income home energy assistance program. Can we go to the next slide? Sorry, there was a 4th recommendation. So the final recommendation for the problem statement 2, that's really connecting the pandemic-related health risks to inequitable access to natural resources, is the federal government must ensure that through that every dwelling in the United States, including tribal nations, has access to clean water and sanitation. This involves using a reliable indicator such as the Health Social Vulnerability Index. I think this is one of our experts talked about during an earlier part of the meeting, using the Social Vulnerability Index to accurately assess the level of exposure to hazards within our most at-risk communities, but including but not limited to tribal nations, and establishing and adjusting a national standards and strategically targeting funding for water, sewage, and air quality to where it's needed the most based on the data from reliable equity indicators. Can we go to the next slide? The problem 3 is our committee's attempt to really address the legacy of systemic racism and sexism. Our experts have really reinforced the importance of both the legacy of systemic inequities, the importance of really leading with equity. So we really echo that problem statements that experts have talked about. And so talking about that legacy in our American medicine research to explicitly stating that the inequities connect to disparities in health outcomes and really decreases the institutional engagement and collaboration that is very much necessary to respond for future pandemics. So here our one recommendation is the federal government to both practice and incentivize healthcare communities to practice, engaging patients and communities across race, gender, cultural difference, across race, gender, and cultural differences in the work to develop appropriate products and solutions, really looking at making sure these are appropriate culturally and socio-demographic wise, but also I would say regionally. Can we go to the next slide? The fourth problem statement is really looking at what was the impact of the pandemic in our education system, right? Both the pre-K to 12 schools and post-secondary institutions, right? Really, I think the pandemic really exposed the lack of infrastructure and adequate funding to support both the quick and frequent and sustained shift from virtual classes to in-person, to really be flexible to meet the demands of what our students needed across the states and territories, right? And I think this is really evidenced by the disparities in access to broadband, the internet technology during this pandemic, and that's particularly also tracking the communities, Black, Latinx, and American Indian, Alaskan Native communities that have borne the disproportionate impact of the disease and the subsequent harm. And so I think that diminishing access to education is really connected to the digital divide. And so really thinking about, as we prepare for future pandemics, how do we bridge that digital divide, which again is very much connected to diminished access to education, but that is tracking the disparities along race, ethnicity, and regions. And so here we have one recommendation that the federal government should provide for appropriate technology and training to students and teachers and faculty members in order for them to enable and assure quality education and any related services, and for them to ship really dynamically and smoothly between in-class and remote teaching contexts. This involves training on the use of for both hardware and software, as well as providing for any kind of stipend that communities need for access to the internet. I think one of the experts talk about I can't remember the exact number, but just the millions of people who still don't have access to the internet. Can we go to the next slide? So the final statement, again, I think echoes the comments made by the earlier Committee on Health Access and our experts, the clear lack of minoritized, marginalized, and medically underserved population within our healthcare pipeline, educational mentorship program, leading to a gap in the healthcare workforce. That our current demographics of the healthcare workforce simply do not represent the diversity of who's living in the United States, and that it's really talking about looking at trying to make sure that there is connection between patients and their caregiver providers to ensure superior clinical outcomes. The recommendation we have here that accompanies the recommendations of other committees is to increase the amount of racial, ethnic, and disability data on the healthcare workforce and educational pipeline across healthcare professions and centralize it in an easy to access and financially maintained database. Doing so may facilitate research into factors contributing to increased workforce diversity, as well as understanding the association between these factors and health outcomes. I'll stop here and that invite the other members of the Structural Drivers Committee to weigh in and emphasize anything I missed and share their perspectives. Thank you.
Yes.
Go.
Oh, no, I was just going to say, Chair, you and I believe you have two subcommittee members. I don't know if you can see them in queue.
Great, thank you. Ms. Turner?
Okay, first of all, I can't thank the task force enough for asserting that when it comes to pandemics, we need to act on the basis of science and not politics, with the common goal of ending and preventing pandemics. We need to ensure that the public health guidance is based on expertise of infectious disease and occupational health and safety experts, including experts in airborne diseases. With the new variants and so much of it so uncertain right now, we can't afford to wait till the next pandemic. We need to act now. We need to support and enforce science-based guidelines and protocols for testing, treatment, and vaccine access in every part of this country. We need to act on the precautionary principle during this pandemic and every future pandemic, and we must ensure that everyone has the highest level of protections, not just the ICU nurses, but all workers. We also need to do our part to ensure equitable global vaccine access to prevent the emergence of new variants or antibody-resistant strains from prolonging the pandemic. As a nurse, I'm a patient advocate, and I know that none of us will be safe until all of us are safe. A global pandemic requires global solutions. Thank you.
Thank you, Ms. Turner. Mr. Watts, sorry.
Yes, okay. Thank you. And I also want to thank you as chair of our committee, Ms. Yoon, and all of our committee members. I just want to say I appreciate some of the recommendations and some of the language around that. And as Dr. Okafor mentioned in her overview of our themes for the whole, for all four committees, there's quite a few places in this committee and others where we talk about rewarding and incentivizing equity. And I think that is super important if we're going to achieve it. We know that what is measured and rewarded and incentivized is what gets done. So the more that we can do that in our recommendations, the more important it is. And the second one is just a note on language. I really appreciate that we are using the phrase repeatedly about the practice and legacy of racism. Legacy is something that's rooted in the past, whose effects are continuing now and in the future, but it's over. But that is not true for racism. The practices of racism are continuing. So I appreciate we're not just referring to the legacy of racism and other sources of inequity.
Thank you for that emphasis, Mr. Watts. Anyone else? Without others, I'm going to turn it back to Madam Chair. Thank you.
Fantastic. Thank you so much, Chair Yoon. Congratulations, of course, to you and to all the subcommittee members. Again, going very deep this cycle, as always, incredibly helpful interim recommendations. Would any of the members of the task force offer up comment or question to structural drivers and xenophobia at this time? Dr. Khaldun, please.
Yes, thank you, Hayoung. Thank you, Madam Chair. Just great recommendations. I just wanted to put a finer point on the recommendation about the healthcare workforce pipeline and just the importance of diversity in the pipeline, getting people to becoming a physician and working, but also making sure, particularly for minority physicians, that they are supported in their roles, that we have more people from minoritized, marginalized communities who are in leadership roles in academic institutions. That's really important to help with that pipeline. Unfortunately, we're seeing many minority academic physicians, especially, who are leaving academia, and that has significant impacts, not just on treating individual patients, but also on research that's done, on further pipeline and mentorship programs. So I just wanted to emphasize that point. Thank you.
Thank you so much, Dr. Khaldun. Necessary. Well, good, thank you. I do not see any other members in queue at this time. So congratulations again, once again, tremendous recommendations. I'll turn it over to you, Dr. Okafor, please.
Thank you, Madam Chair, and thank you again for members of our structural drivers and xenophobia task force members. You did exceptional job in addressing issues pertinent to that area. And now, with just great joy, I would love to introduce the next subcommittee, and that's the subcommittee that focused on communications and collaborations across our governmental, non-governmental partnership, and lifting up innovative ways that we could partner with our communities that are disproportionately impacted, as well as create communication to address this issue. Love to introduce Andy Imperato to come and take it along.
Thank you, Dr. Okafor, and I want to start by acknowledging my fellow subcommittee members, including the chair of our subcommittee up until this month, Myra Alvarez, who is now on parenting leave, as has been mentioned, but I also want to acknowledge Octavio Martinez, Vincent Toronzo, Jolinda Johnson, and Rachel Levine, who are all part of our subcommittee. And I really want to thank and acknowledge the staff who are listed here, including our interns. We've had phenomenal interns on this subcommittee, and the help that we've gotten from the consultants at Deloitte. We've had great support in the subcommittee, and we're grateful for it. I also just want to note that this week was the 31st anniversary of the Americans with Disabilities Act, and it was exciting to see the civil rights enforcement agencies across the Biden administration coming together and issuing guidance around the civil rights for people with long COVID, which was something that we had recommended during our long COVID sprint last month. So just an example of the kind of collaboration that we're calling for. I'm very excited to see that this week. So if we could go to the next slide. So I think I'm going to follow what Hey Young did, and if we could just go to the combined problem statement with the recommendation, that'd be great. So the first one is something that we heard loud and clear from our expert panel today, which is the importance of communication and collaboration between public health officials and public emergency management. I think one of the things that we learned in our work this month is that in many states at the beginning of this pandemic, the top public health official and the top emergency response official didn't necessarily know each other. So those relationships were not in place at the beginning of the pandemic across all levels of government. And it's interesting that at a time when some of our public health budgets have gone down, the emergency preparedness and response budgets have been going up, in part because there have been so many overlapping disasters between hurricanes, wildfires. I mean, just California alone has had so many overlapping disasters. So we feel it's critical to tap into the capacity and the expertise that has been building in the emergency preparedness and response world. And again, we were excited to hear that recommendation from the expert panel that we heard earlier today. If we could move to the next problem statement. And again, this is one that has been touched on in other subcommittees. A global pandemic is just that, it's global. So when we think about collaboration, it's important for the United States to recognize that we have a role in collaborating with other countries and international bodies as we try to respond to the pandemic. So the recommendation that we have in this area is for the US to take an active leadership role, bringing an equity lens to international pandemic preparedness efforts. And we feel that the US role in responding to pandemics across the world should better prepare us to respond to pandemics in the US, and this kind of international collaboration is critical. Next slide. So this slide is really about coordinated, equitable response to the pandemic. I think this echoes some of what we heard in structural drivers and healthcare access and quality. We want to look at everything from acute care delivery, long-term care, EMS, public health, the private sector, developing vaccines and other treatments, and then healthcare equipment manufacturers. The bottom line is we need to look at how all of these systems can come together better to respond to the pandemic with an equity lens. So the overarching recommendation here, which was called out by Dr. Okafor in her overview, is, and again, this echoes something we heard from our expert panelists earlier today, the federal government should appoint an independent blue ribbon panel to conduct a COVID-19 pandemic after action analysis for the whole of government. And the whole of government emphasis is important from our perspective, because if agencies do this one at a time and just look at how they could do better as an agency, we worry that we're going to miss the opportunity for collaboration and for responses that can leverage expertise and capacity that exist in other agencies. So we're hoping that whatever analysis is done, part of it looks at the entire government and how we've responded to the pandemic. Next problem statement. And this echoes things that we've heard, I think, from so many people today. We did not get the kind of unified, science-based, non-political, trusted voice to educate the public about PPE, therapeutics, and testing. And because of that, our response suffered. There was a lot of confusion. There still is confusion and misinformation. Some of that is being delivered to minoritized, marginalized, and medically underserved populations in a way that is interfering with people getting the vaccines and doing what they need to do to protect themselves. So again, we're echoing what we've heard from other subcommittees today. Federal government should establish a consistent communication to educate the public about PPE and therapeutics and testing using science-based, non-political sources. One of the things that we've talked about in our subcommittee is part of it is a consistent message, and then part of it is having diverse messengers who can deliver that message with credibility to different audiences. So there's a lot of room for improvement here. And again, we're echoing what we heard from other subcommittees. Next problem statement. So this really, and we heard this loud and clear from our expert panel, goes to the inconsistent funding that we have allocated as a country for pandemic preparedness and response. So the recommendation here is pretty straightforward. The federal government should establish consistent and adequate funding for pandemic response and should find a way to protect that funding from ups and downs in priorities. This is a priority that should not go away. It's a life and death priority. It benefits from consistent funding and long-term planning. So we're encouraging the federal government to find a way to do that. And we've certainly done that in other areas that we establish as national priorities. We've got two more problem statements, so we can move to number 6. This one is really about communications. The public messaging around this pandemic has not adequately considered the cultural, linguistic, and geographic context for minoritized, marginalized, and medically underrepresented communities, and especially for indigenous populations. So we're calling on the federal government to provide guidance to state, local, tribal, and territorial governments, as well as federally qualified health centers, on how to reach these diverse communities in a way that is going to resonate and help folks make good decisions around the pandemic. Providing guidance on the creation of preparedness plans that are responsive to these various communities and involve them in developing the plans, and then identifying and establishing partnerships with state and local policy organizations that have deep knowledge of these minoritized and marginalized communities. And then if we can move to the next slide, the final problem statement is this really goes to the culture of public health. And I saw this play out in California, both from our statewide public health agency and then our 58 county public health officials across the state. Many did not have the relationships that they needed to have with communities that were being disproportionately impacted by the pandemic. The one that I'm most familiar with is the disability community. I think our California public health infrastructure has learned a lot about how to work with people with disabilities during a pandemic. But under this problem statement, we're calling on the federal government to provide guidance to public health officials on establishing expectations that staff and management engage in activities designed to advance health equity. So building deep relationships in these communities and knowledge of the communities. Federal government should provide guidance to public health officials on establishing and maintaining strong and authentic relationships with communities who are experiencing inequities. And the federal government should provide guidance on the collaboration between government and private sector entities that already have strong relationships with minoritized, marginalized, and medically underserved communities. So I'm going to stop there and see if any of the members of the subcommittee would like to add anything. Octavio.
Andy, thank you for being a great chair and during this time, and also to my colleagues on the committee. I think this has been fabulous. This is really more of a comment, especially relates to communication. I think communication, you've highlighted many of the really good recommendations how we need to communicate. But I think it's also important for us to realize that the words that we use are equally powerful and important, but also the concepts that we're discussing and conveying. And we must be respectful. And in fact, we need to model of how that actually should be done. And I think a good example happened today with one of our speakers, Dr. Scorton, when he was willing to talk about when it came to burnout. The fact that we're willing to talk about burnout is huge, in my opinion, that we're now actually having that kind of a dialogue. And it's not just in the, being, pushed aside or ignored, because it does impact the ability to communicate and to collaborate, and my counseling himself personally. And it goes to the highest levels, and it is worldwide, of how we communicate with each other, and especially concepts. And I'll take, for example, even at the Olympics, it's become an important issue, and I'm glad to see that kind of a concept to help folks to understand how the human body, the mind body, is totally connected. And an injury to the neurological system, as we said, as behavioral health or a mental health issue, is just as important as a physical illness. And why is that so important? Take a look at how COVID-19 has impacted each and every one of us, and unfortunately, some of us disproportionately more than others. So just a comment, but within that concept of communication are also these, I think, really important, concepts, as well as the words that we use. Thank you.
Thank you, Octavio. I see. Well, I don't see anybody else who's on the subcommittee with their hand up, so I'll turn it over to you, Madam Chair, and you could call on my good friend, Dr. Caldew.
Wonderful. Thank you so much, Mr. Imperato. Chair Imperato, thank you for stepping up. Congratulations, of course, from all of us go out to Myra Alvarez and her family as they are celebrating and welcoming a new addition to their family. Really great, phenomenal, as is the expectation, quite frankly, but certainly really key, and appreciate Octavio's comment as well. Dr. Martinez, thank you for that. Dr. Caldew, please.
Yes, thank you so much, Mr. Imperato, Madam Chair. I wanted to make a comment about the recommendation on the fact that public health agencies at both the local and state area level need to engage with communities. I 100% agree. I agree with guidance, but I think also understanding the issue of lack of funding and lack of staffing. Having been in leadership roles at the local and state level, oftentimes they're very limited staff at these departments, and it's very difficult to do all the great on the ground work and relationship building. That's really at least one person's full-time job, if not more. And so I found it very difficult when you have limited staff is being cut, as we've already discussed here today and from our experts. But I think that's a really important recommendation. But I just wanted to emphasize, if we funded public health well, we would also see improvements in some of that core public health work, which is appropriately engaging and having relationships with the local community.
Thank you, Dr. Caldew. I was so busy nodding that I forgot to take myself off mic. Thank you so much. Dr. Hildreth, please.
Thank you, Andy, and thank you, Dr. Vivian Smith, for the opportunity to comment. I have a comment about problem statement number 2, related to the United States taking an active leadership role in pandemic preparedness. Without question, our healthcare enterprise and our biomedical research enterprise are the envy of the world, but that doesn't mean we can't learn from other countries. One of the things that profoundly disturbs me is we could have learned so much by watching what happened in India, Australia, and some other places. The Delta variant didn't have to catch us with our pants down. There are things that we could have learned to be better prepared if we had paid attention to and acknowledged the value of what was learned in these other countries. So my recommendation to whomever is in charge is that we be intentional about trying to learn from others and how they have dealt with the pandemic. So we can take an active leadership role, but there's also some room for some humility, cultural humility, to know that we can learn from others as well. Thank you, Madam Chair.
Critical point. Thank you so much, Dr. Hildreth. I think, great. I do not see any other hands in queue. I think that is a very important point for us to close our conversation on the interim recommendations from the Communications and Collaboration Subcommittee. Thank you again to all of you for that great work. Dr. Okafor, I believe we have one subcommittee remaining.
Yes, Madam Chair. Thank you so much for all the great work that our Communication and Collaboration Subcommittee did. And of course, we are getting to our 4th subcommittee, and I am so delightful to introduce the Data Analytic and Research Subcommittee, because I know they did a superior job in addressing all the issues, or most of the pertinent ones, relating to data challenges that we have. So, introducing Dr. Janae Kadun. Thank you. Take it along.
Thank you so much, Dr. Okafor. And of course, I want to again thank my subcommittee members, many of who also serve on other subcommittees, so they do a lot of work. Dr. James Hildreth, Angie Imperato, Victor Joseph, and Dr. Homer Venters. Again, just great July sprint, and thankful for their dedication. I also, of course, want to thank the HHS staff, our wonderful interns, and our lovely chair, Dr. Marcella Smith. So next slide. For this month, our subcommittee actually had 9 problem statements and subsequent recommendations that I'll go through briefly. The first problem statement that you can see there really speaks to the lack of a robust and real-time data system and the structures in place to actually be able to appropriately respond to the pandemic. This is a theme that you've seen throughout this task force work over the past several months, but we thought it was really, really important to elevate that issue again here. Our second problem statement is about the fact that many healthcare workers and just really frontline workers in general, not necessarily working in a hospital, but they did not have access to sufficient PPE. And the data infrastructure was really lacking to sufficiently track and assure equitable availability of PPE and other critical supplies across the country. Really, states and municipalities and hospitals were just left to figuring it out on their own and trying to find PPE really in a scrappy, uncoordinated way, which really hindered the pandemic response. Problem statement 3, again, has been brought up before, talking about the lack of a data infrastructure, systems, and expectations, actually, the lack of that being in place to support collection and reporting of disaggregated data. Again, really just a lack of real-time sharing of data and actually special pathogen threats, which is really important for a pandemic response. Next slide, problem statement 4. Further emphasizes this lack of disaggregated data and how that negatively impacts our ability to understand how the pandemic is impacting subpopulations, and this includes veterans. This is particularly concerning, and again, I have this experience in my own work, given some populations receive their health care from the Indian Health Service or the Veterans Affairs Administration, and those systems have their own kind of data systems, and they don't connect to public health systems. So it can be very difficult to understand and track testing, vaccinations, and other things because there are silos there. Problem statement 5 states that even though standards for data compliance exist, unfortunately, they often are not properly executed. And so often preparedness trainings focus solely on the medical system. Public health departments, they do have their own public health emergency preparedness programs, but they often, when they're doing those trainings and tabletop exercises, they often don't actually involve the broader community. And they often actually don't really test and work to improve data sharing capabilities. And we saw that play out with the COVID-19 pandemic. On the next slide, statement 6 talks about the lack of integration of data systems, not just between local, state, and federal governments at all levels of government, but also between health systems, medical providers, and public health data systems. And again, really just impeded our pandemic response. Our next statement talks about a lack of marginalized, minoritized, and medically underserved people being appropriately represented in research, whether that's, again, the leaders of those research studies actually, or as actual participants in trials. Again, not a new phenomena here in this country, but it really bore out during this pandemic. And I'd also say there's also a lack of funding for equity-based research across the country. Our last two problem statements, problem state similarly talks about a lack of inclusion of minoritized communities in clinical trials, again, leaving gaps in our understanding of the effectiveness of these interventions. And then statement 9, again, a theme that we've heard about today, talks about what we've found during this pandemic with the risk associated with people living in congregate settings. And it's not just nursing homes, it's adult foster care, it's homeless shelters, as those in the criminal justice system. We really need more research to be done to understand the factors associated with this increased risk and how to mitigate them. So next slide, I'll go through our recommendations. So for our first problem statement, we had 2 recommendations. And they really focus on investment in preparedness, specifically around data capabilities, as well as a recommendation to focus on addressing equity in how special preparedness plans are actually implemented. On the next slide, for problem statement 2, we actually had 6 recommendations that I'll paraphrase here, but they really focus on strengthening tracking and reporting of PPE and other essential supplies, assuring supplies are properly maintained at a local level, so sufficiently maintained and not cut back, making sure there's proper training for just basic PPE, donning and doffing, something that hospitals have to do, but making sure we're really focusing broadly on making sure that training is happening on a regular basis. And also importantly, focusing in on and addressing the equity gap that exists in availability of PPE and protecting our marginalized and minoritized communities, as well as the people who serve them. One of our experts earlier talked about how our Black and Brown clinicians who were serving Black and Brown people often felt that they did not have access to PPE more so than in other communities. So that was certainly a problem. Next slide, for problem statement 3, we had 4 recommendations. One was to create, again, this theme of standardized reporting expectations with disaggregated data, again, very important, and incentivizing the reporting of that data. And again, the need for investment in state, local, territorial, and tribal data and surveillance infrastructure, and then leveraging that data in a centralized dashboard. And finally, we really, as was just mentioned, we need to learn from other countries and improve the sharing of data and experiences, quite frankly, transnationally, that would allow for a more robust response and for us to be able to respond more quickly, not just robust, but with speed, which is very necessary. For our next problem statement, we had 3 recommendations. One was to incentivize partnerships so that demographic subgroups are better reflected in preparedness efforts, and we can actually track how they are impacted. Again, developing standards for the collection and reporting of such data, and that more rigorous standards are put in place to protect against the misuse of data, using data or omitting data, quite frankly, for political reasons. And particularly, this has a negative impact on marginalized, minoritized, and medically underserved communities, including those who are undocumented and those who are involved in the criminal justice system. For problem statement 5, 2 recommendations there. Really, they were around assuring that entities are compliant with current data standards, and also wanting to really identify any challenges or barriers to being compliant, and also making sure broad community organizations outside of the traditional public health departments or healthcare systems, really making sure they're also strategically involved in training and preparation for special pathogen events. For problem statement 6, next slide, we had 4 recommendations. One is that an environmental scan really should be done to more thoroughly understand our current reporting requirements for different things throughout the pandemic, identify areas of alignment, and then use these existing systems that are already being used to report data to create a more streamlined, real-time as much as possible, and coordinated process for data reporting across agencies. And importantly, we don't just want this data to be reported, but it really has to actively be used to improve collaboration and coordination when it comes to resource allocation. Next slide. So for this problem statement, we had 4 recommendations focused on analyzing the inequities in research funding and barriers to accessing this funding. So we actually recommend that a research network be developed that really enables greater sharing of research, more robust understanding of rapidly changing data, and importantly, I think to my earlier comments, enabling proper inclusion of minoritized, marginalized, and medically underserved communities. And we also want there to be federally supported biomedical research to be inclusive of these groups and additional grant funding that really does talk about or address the fact that a lot of these challenges we're seeing in the disparities and inequities are about syndemic issues and the multiple health risks and cumulative exposures that these communities face, and puts them at even greater risk when disasters do strike. For problem statement 8, similar to what I just talked about, but it really talks about broader representation and inclusion of minority groups in clinical trials, both for vaccines and therapeutics. And so we had recommendations that focus on inequities in access to clinical trials, developing standards for equity in clinical trials and treatments, and also including enrollment targets that are really representative of populations that are disproportionately impacted by these events. And then for our final problem statement about congregate settings, we had 1 recommendation, and that is that we really need to understand and study the risks associated with congregate living settings and pathogen spread, and making sure preparedness efforts really consider these risks in determining resource allocation and future preparedness planning. And I'll just add there, while we certainly need to do more research and use data and understand, there's no question that people living in these settings are at higher risk, and there are things that you can do immediately. To an earlier comment by Dr. Venters about early release, you can do things that protect people in these settings. So thank you. I would like to certainly turn it over to my subcommittee members to add their additional comments. Let's see here. Quickly. I do not see any hands raised. And so I will turn it back over to you, Madam Chair.
Thank you so much. Oh, wait a second.
No, never mind. No, she's not in my subcommittee. Go ahead, Madam
All right. Great. Well, thank you so much, Chair Caldoon. Again, kudos to you and all of the subcommittee members. Really appropriate for us to be sort of closing our discussion today, focusing on data analytics and research. I'm particularly grateful that the recommendations were deep and broad enough to also take into account the data ecosystem with attention to important considerations of data governance and others. So Ms. Turner, please.
So it's no surprise that I've been carrying the PPE torch in the past few months. And I just want to express my extreme gratitude for your problem 2 and all of its recommendations. I just couldn't let that go by without expressing my extreme gratitude for all of that. Thank you.
Fantastic. Dr. Martinez, please.
Dr. Caldoon and the DAR subcommittee really want to commend you on these recommendations. I think they're just fabulous because it really talks about the data analytics and research infrastructure that we really need for the 21st century. Because these DAR recommendations, to me, they don't only speak about these are investments that will strengthen not only our nation's health, but in fact will strengthen, and I think people need to realize it goes so much beyond that now, our nation's economic viability, and in fact, our nation's defense as well. That's how interrelated all these systemic issues are. So I just wanted to make that comment and thank the subcommittee for the tremendous work.
Exactly. Good. Thank you, Mr. Watts.
Thank you, Madam Chair. And I'd also like to thank the subcommittee for their recommendations and for recognizing the impact of congregate care and also importance of capturing the social determinants of health as we prepare now for what data we want to collect in advance. I urge us to continue to do that, and especially I'm focused on that we collect data on housing status on people who are experiencing homelessness. With a very brief anecdote here in Nashville, where our office is headquartered, our agency is headquartered, a local health provider at FQHC was very involved with this larger city's response. And they said, oh, we would love to collect housing status, but the data fields are already set. So getting that in advance could be really helpful. They later went on with a special initiative to try to vaccinate people experiencing homelessness, but we need a system-wide understanding of the problem and response and ability to collect the data and analyze it and use it. So thank you.
Thank you, Mr. Watts. Excellent. All right, fantastic. Let me just take a moment here to say that we've now heard from all 4 subcommittees for this cycle and interim recommendations related to our future preparedness. Extraordinary work. We as a group, I think, are so incredibly grateful for the expertise and input of the subject matter experts who join us, of the guests who join us here in our public facing meetings. I do want to just take a moment to, of course, acknowledge the immense expertise that is here in the members of the task force all. And so thank you, each one of you, for bringing that expertise, for bringing lived experience, and for bringing that deep passion and advocacy to this work all the time. We are coming up on a break. Before we do take it, I'm going to turn to Dr. Okafor, because I think it's important we also acknowledge the expertise that so many others bring to make this work possible. Dr. Okafor.
Thank you, Madam Chair, and just echoing your compliment and deep appreciation of every member of the task force. It is clear that, the excellent and wonderful and brilliant job they've done covering these complexities of this endemic that we are going through in this COVID-19 is really beyond just comprehension, because you guys did exceptional job within a short period of time. Just saying thank you so much for all your sacrifice, because I knew took a lot of your sacrifice of your time and everything to get this work done. I also wanted to take a moment to thank our staff, because I know as you were working, the staff are working so hard, weekends, late at night. And just wanted to thank Jamie Babin, who is our special assistant. I wanted to thank Shandell Wilson Frederick, who is our implementation manager, as well as Cheryl Levine, who is operations manager, and of course, Dr. Phil Blank, who is our project director. And I also wanted to thank especially our interns. Some of them are leaving this month, and I just wanted to commend them publicly because they've done a lot of the heavy lifting. And there are Sydney Gray, Swati Srinivasan, Thomas, known as Tag, Quigiano, and we have Maya McCoy, as well as Beverly Udebe. So I wanted to thank all of them, and Victoria Bartlett, who joined us and continue to work with us on that, the implementation work. Thank you so much for all the work you've done. And for Deloitte, our team, Deloitte Co-Former, we couldn't have done this without your support and amazing work you're doing. And thanks to CDC Foundation for their generosity to fund Deloitte to support us in moving this work forward. Over, Madam Chair.
Thank you so much, Dr. Okafor. Tremendous. So at this point, we'll take a break. I know we have folks who are anxious for to join us for public comment. I have now 27 after the hour. With apologies, you get a stretch break, a couple minutes. We're going to start public comment at 5:30 Eastern Standard Time.
Madam Chair, I forgot to say thank you to Cherise Perry. And
oh, yes, absolutely. Thank you.
Yes, who has been amazing in all the communication and outreach. Thank you. Over.
Stretch, everybody, and be back. back, everyone. Really critical, congratulations again. Really important discussion so far in all parts of our meeting. Now we have, I think, part we all look forward to, very important to hear public comment. Captain Wu, I'll turn it over to you, please. Thank you for facilitating our public comment.
Thank you, Madam Chair. So as with all federal advisory committees, this is an opportunity for the task force to receive comments from members of the public. We received quite a few of comments requests today to deliver comments. So I will announce the speaker's name and affiliation. So when you are called, you can go ahead and unmute yourself. If you are on the phone, press *6 to unmute. First, we will hear from Ms. Colleen O'Brien from the Nassau County Juvenile Detention Center. Ms. O'Brien, you have 3 minutes, and please proceed if you're online. Okay, I do not hear her. Next, we will hear from Ms. Lily Grayman from the University of Montana. Ms. Grayman, you have 3 minutes, and please proceed.
Hello, thank you. My name is Lily Greiman, and I'm a project director at the Research and Training Center on Disability in Rural Communities at the University of Montana, and a representative of Disability Data Advocates Taking Action, or DISDATA. DISDATA is a collaborative of advocates, researchers, disabled people, and service providers promoting disability data equity. DISDATA formed in the midst of the COVID-19 pandemic as the group saw how difficult it was to access, analyze, and understand the limited data that were available on the impact of the pandemic on disabled lives. People with disabilities were already made invisible pre-pandemic across federal policy through the lack of data collection and representation, which then means researchers, policy leaders, disability leaders, policymakers, and service providers cannot make informed decisions to improve the lives of people with disabilities. Lack of representation means that disabled voices and lives are excluded from American society. The COVID-19 pandemic has highlighted this long-standing data disparity and emphasized that disabled people are missing from the data, but overrepresented in deaths that we know about. Addressing this data inequity is critical during the current pandemic when people with disabilities are disproportionately living and dying in congregate settings, such as nursing homes, group homes, intermediate care facilities, psychiatric hospitals, detention facilities, carceral facilities, and other congregate shelters. We have very little information because of disjointed data collection about what the experiences of disabled people are in congregate settings, especially when looking at health equity and intersectional issues such as race, kinds of disability, primary language, etc. However, we do know that as of July 18th, 2021, at least 133,519 disabled people have died in nursing homes, which report to the Centers for Medicaid and Medicare Services. We know that disabled people in nursing facilities continue to be at risk, with only 22% of those same facilities that have staff vaccination rates above 75%. These deaths will not end unless we recognize that congregate settings are dangerous environments where individuals are put at high risk of disease and death. Efforts to prevent future death must include support of disability-led organizations like Centers for Independent Living, who have proven and effective strategies for transitioning and relocating individuals from congregate settings into the community. In addition, systems must be in place to prevent individuals from entering unsafe, high-risk congregate settings in the midst of a pandemic. Finally, DISDATA recommends improved disability recommendation across all levels of data management, and this means centering disability in all data decision-making processes via the meaningful inclusion of disabled people, disability-led organizations, disabled advocates, activists, and researchers in defining data priorities, identifying data disparities, measurement development, data collection, distribution, data analysis, knowledge translation, development of data-driven policies, strategies, and solutions. And then finally, the goal of DISDATA is to build a network connecting advocates, researchers, service providers, and policymakers around a shared goal of improving access to and representation within disability data systems. So thank you so much for your time. This has been wonderful to sit in, and I'm happy to have the opportunity.
Thank you, Ms. Grayman. Next, we will hear from Dr. Harold Schmidt from the University of Pennsylvania. Dr. Schmidt, you have 3 minutes, and please proceed.
Thank you. My name is Harold Schmidt. I'm an assistant professor of medical ethics and health policy at the University of Pennsylvania, somewhat addicted to your work, as really any medical ethics professor should be, of course. This is, again, such important progress, and the country is so fortunate to benefit from your work. I'm also grateful for the opportunity to provide brief comments now on 2 points that are directly connected to today's discussion, and both of those relate to disadvantage indices, such as the social vulnerability index mentioned several times earlier, that have been adopted in an unprecedented and important way in vaccine allocation to promote health equity, and that have considerable potential to accomplish the same beyond the pandemic. So first, the meeting today is focused on future pandemic preparedness, but not just given the Delta variant, the pandemic isn't over, and there's an active discussion about booster vaccines, where it seems the group's recommendations could be immediately useful. Clearly, the question of boosters has to be driven by science, and ideally, given the unbearable global vaccine access disparities, we'd only roll out boosters if this does not compete with closing the unacceptable global vaccination gap. But if and when there is reasonable case for boosters, initially there will again be severe scarcity. An immediate lesson from the vaccine rollout to date is that phased allocation frameworks need to be combined with a disadvantage index, whether this is the CDC's SVI, already adopted by the majority but not all US states, or another index. Of note, in 2 studies that colleagues and I fielded, survey studies, fielded just before the end of phased allocation in April, we found that a majority of Americans supports the use of disadvantage indices as implemented. And there was only low rates of complete opposition. These studies aren't published yet, so I'm leaving this somewhat general now, but I'll share them separately, hopefully soon. Second, the adoption of disadvantage indices in the current pandemic was unprecedented, rapid, and widespread, with at least 37 CDC jurisdictions, including 34 states, using them. They clearly met a need, and more long-term should be part of all future pandemic plans. But there were also at least 8 different types of indices in use, and 2 weeks ago, in an important development, the Office of Minority Health and CDC launched the new Minority Health SVI. So longer term, there's a need to ascertain which types of indices are best suited for which purposes, as there are important differences between indices. For example, the air deprivation index operates at the block group or neighborhood level, 600 to 3,000 people, whereas the SVI's smallest unit is the census tract, 1,200 to 8,000 people. And the new Minority Health SVI currently operates at the county level. But given how diverse geographies, especially in cities, can be over small distances, unadjusted and overly coarse measure can needlessly obfuscate important disparities. There are also differences in the share of communities of color that different indices capture, and a number of other trade-offs associated with integrating particular variables that merit attention. I'll share separately a review in which colleagues and I describe these and other differences in more detail. Now, to be clear, for now and for possible boosters, using any disadvantage index is vastly superior to using none, and using one is critical for both equity and public health. But disadvantage indices also hold considerable potential for promoting equity outside of the pandemic and health emergencies, as we found in another review of the literature. And hence, a clear understanding of the different types of trade-offs that can arise in using disadvantage indices is really important. I thank you again for the opportunity to provide a comment here and for all the amazing work that Chair, the task force members, and the staff are doing.
Thank you, Dr. Schmidt. Next, we will hear from Dr. Colleen Kraft from the Emory University Hospital. Dr. Kraft, you have 3 minutes, and please proceed.
Thank you. Thank you for the opportunity to address this COVID-19 Health Equity Task Force. I'm an infectious disease physician and clinical microbiologist, serving as the Associate Chief Medical Officer of Emory University Hospital. I've had the opportunity since 2015, when we cared for patients with Ebola virus disease at Emory, to participate in the National Ebola Training and Education Center, which prepared healthcare systems for pandemics. While we created an infrastructure to educate and create areas of safety for healthcare systems, starting with Ebola virus disease, this pandemic has challenged all of our systems to depend on our teamwork to not only care for our patients, but also our healthcare workers on the front line. At Emory University, we've been very, very concerned about the inequity that has occurred for persons of color in underserved communities. In April of 2021, Emory came out with a health equity dashboard, and this data can be found and analyzed from the nation down to the individual county. I think and hope that these types of platforms are the types of things we can get for people to understand the context around them. I think there's been very much that we've struggled through this communication of public health information. And I hope that platforms and data analyses and getting these types of things out to individuals can have allow us to have a clearer vision of what groups are disproportionately affected around us and how we can act. You will see easily on this dashboard that there's an increased COVID-19 death rate per 100,000 individuals in Black Americans, which is greater than COVID deaths in other ethnic groups, as well as evidence of a lower vaccine uptake. We are very proud that Emory University and Grady Health System participated in studies for therapeutics and vaccination, enrolling 50% in the Moderna vaccine trial specifically that were underrepresented minorities. While we did much work reaching out to persons of color in underserved communities, it is clear that the inequity cannot be abruptly solved during this particular crisis. There are longstanding concerns in these communities and will take relationship and trust building in order to bring these communities where they should be. We cannot pour our resources on only for emergencies and then withdraw to the systems that existed prior. I think we've had a chronic issue that now this acute exposure is really bringing to light during this pandemic, and it does compel us to act. This pandemic has really challenged the foundations of healthcare. Even today in my hospital, where we have an extreme surge of patients with COVID-19 due to lack of vaccination and the Delta variant. And we are trying to focus on quality care for our patients and healthcare workers. And we are compelled to focus on equity for the care of our patients at all times. Thank you.
Thank you, Dr. Kraft. Next, we will hear from Dr. Pamela Austin from the National Dental Association. Dr. Austin, you have 3 minutes, and please proceed.
Thank you for the opportunity to make a public comment. I am president of the National Dental Association, the NDA. The NDA supports the health and well-being of all populations, especially Black and other communities of color, as well as other underserved populations. The NDA supports racial, educational, and health equity. During this time of the COVID-19 pandemic, the NDA welcomes this administration's leadership in informing future pandemic preparedness and mitigation. The majority of our members provide care in resourced poor communities. And as a result, we support equitable response and recovery centered on communities most in need. Such a response may include collecting high quality and complete data that capture accurately morbidity and mortality of COVID-19, improved practices that include investment, education, greater access, and resources to enhance communities disproportionately impacted by COVID, as well as the inclusion of members of the dental team in coordinated recovery efforts to improve population-level health. It is our hope that evidence-based approaches addressing upstream social and political determinants of health will be used. We look forward to collaborating with our stakeholders and developing new partnerships to be active participants in this nation's recovery and preparedness efforts. Thank you.
Thank you, Dr. Austin. Next, we will hear from Mr. John William Templeton, a publisher and author. Mr. Templeton, you have 3 minutes, and please proceed. Yeah, I see that he's still trying to make the connection, so we'll move on to the next person. Next, we'll hear from Mr. Nick Gutta from the Survivor Corps. Mr. Gutta, you have 3 minutes, and please proceed.
Thank you for having me. I'm an advisor to Survivor Corps, the largest organization, advocacy group in the country for people with long-haul COVID. I'm here really to talk about the mental health issues of this. 13 months ago, my wife, Heidi Frere, was a healthy 50-year-old woman who walked 90 minutes a day and was in perfect health. Long-haul COVID took away everything from her. She had excruciating pain and in various parts of her body, from diabetic nerve pain that she was not a diabetic to tachycardia, POTS, etc. And in the last 4 weeks of her life, she unfortunately developed terrible tremors and internal vibrations, neurological, that caused her basically to not be able to sleep at night. And she took her own life 8 weeks ago because she was so desperate and so feeling without hope. I literally came home and found her hanging in our house and had to protect my son from seeing this. I can't tell you since then how many people have contacted me on social media because they are feeling the same way she is. They feel desperate. They have these internal tremors and vibrations. They can't sleep. And if you can't sleep, you can't heal. And they also feel like they have no real hope right now, unfortunately, because there is not enough. The research to actually come up with therapeutics is not happening fast enough. I literally talk 2 to 3 people a day almost off the ledge. What we need is a healthcare system right now that provides mental health to them, also provides sleep and rest options like sedation. I know that may be unpopular, but some of these people may need to be sedated for several days because they're staying up 20 hours, 22 hours a day. I can't stress enough that suicide is a very, very traumatic thing. My son will never be the same from this. And there are many families out there who are facing this. We have to get really serious about this. We have to treat this as much of an emergency as the therapeutics. But we need to basically understand that there are many more people like my wife coming down the pipe. I hear from them every single day, and it is terrifying to think that they will go through what I went through. I wouldn't wish it on anybody. I wouldn't wish it on my worst enemy. And she was a vibrant, healthy person who lost all hope because the virus took away every aspect of her life that was remotely pleasurable. So I want to thank you very much for having me. I cannot stress highly enough that it's an honor to talk to you, but please, as a government, we have to take this seriously. We have to start doing this because there are going to be a lot more people like my wife coming very soon. And
Thank you, Mr. Gupta. We'll circle back to Mr. John William Templeton. Sir, I see you online, and you have 3 minutes, and please proceed.
We have to get really serious about this. We have to.
I hope you share my concern that 30 million African Americans are not vaccinated. And we encourage.
Mr. Templeton, can you hold on a second? I think Mr. Gupta is still speaking. I'm sorry.
And it is terrifying to think that they will go through what I went through. I wouldn't wish it on anybody. I wouldn't wish it on my worst enemy. And she was a vibrant, healthy person who lost all hope because the virus took away every aspect of her life that was remotely pleasurable. So I want to thank you very much for having me. I cannot stress highly enough that it's an honor to talk to you, but please, as a government, we have to take this seriously. We have to start doing this because there are going to be a lot more people like my wife coming very soon.
Sorry about that, Mr. Templeton. Please go ahead. We'll circle back to Mr. John William Templeton. Sir, I see you online, and you have 3 minutes, and please proceed.
We have to get really serious about this. We have to.
I hope you share my concern that 30 million African Americans are not vaccinated. And we encourage.
Let me just interrupt 1 second. My apologies. I think there is something. We have a technical challenge. It sounds as though something is on loop.
They will go through what I went through. I wouldn't wish it on anybody. I wouldn't wish it on my worst enemy.
I just asked the technician to kill Mr. Gupta's audio.
Every aspect of her life.
Sorry about that.
It's remotely pleasurable.
I don't think that is it. There is something else going on.
Stress highly enough that
could our technical group look into this?
Thank you.
Just
1 moment.
Mr. Gupta, I don't know if you can hear me. I think your video, your audio is repeating itself. You can mute it or end it. But then please go ahead. We'll circle back to Mr. John William Templeton. So I see you online.
And I don't think he's still online.
We have to get really serious about
okay.
This. We have to.
I hope you share my concern that 30 million African Americans are not vaccinated.
Let me just interrupt 1 second. My apologies. I think there is something, we have a technical challenge. It sounds as though something is on loop.
They will go through what I do. I would wish on anybody. Madam Chair, is it okay to just take a 2 minutes pause and let the technical group correct the issue? Thank you.
Yes, Dr. Okafor. We have until 5:53.
All right, folks, I think we may have resolved the audio issue. Mr. Templeton, would you like to try it again? I'm so sorry about that.
Oh, not a problem. I hope everyone shares my concern that 30 million African Americans are not vaccinated. And at a rate of 150,000 per week, as the CDC site said yesterday, we're looking at 4 years before that happens. And so I urge you to join us during the 18th Annual National Black Business Month in August, starting Sunday, to utilize the 400,000 African American businesses that are in health and social services. We've done 7 meetings leading up to our Pandemic to Prosperity State of Black Business 18th edition report. And we've heard from companies that have been longtime federal contractors in diagnostic tests and epidemiology, but they aren't being utilized by state and local agencies. We also heard from one of the topics you mentioned earlier, from Leslie Baskerville, the president of NAFIO, who insists that the infrastructure spending provide for 5 new HBCU medical schools. And I would, in deference to our earlier speaker, I would say dental schools as well. Because our research from an economic perspective and also from an educational perspective is that the one most important intervention you can make in African American communities is to increase the number of Black doctors. And that has implications for health, has implications for education, has economic implications as well. And so, as many of you know, there were 13 medical schools at HBCUs in 1900, but we haven't had a new one since Morehouse in 1983. So we need to take advantage of this opportunity and the unprecedented spending to give the same kind of resources to creating doctors as we do to nurses. We have 37 nursing schools at HBCUs, so it doesn't make sense to have 4 medical schools and 37 nursing schools. We're at parity for nurses. So we know what we need to do for doctors, and that's how we get rid of the disparities. It also came to my attention that there's not a single medical school on any of the Indian reservations. So those are the kinds of things that we need to do, as opposed to training and papers and that sort of thing. We just need to create the facilities to produce the health workforce.
Okay, thank you, Mr. Temple, for your comments. Next, we will hear from Dr. Malika Fair from the Association of American Medical Colleges. Dr. Fair, you have 3 minutes, and please proceed.
Thank you. Thank you to Chair Dr. Nunez-Smith for your leadership, as well as to the entire committee for advancing health equity in the pandemic, as well as in our nation. I'm Dr. Malika Fair, the Senior Director of Equity and Social Accountability at the Association of American Medical Colleges. You heard from our President and CEO earlier this afternoon. I wanted to make a few comments related to some of the questions that came up earlier and a comment. Dr. Hildreth, you mentioned earlier the importance of intentionally learning from others, and I would urge the committee to also consider that as we discuss our communities who have been marginalized and minoritized, that there are some lessons learned in this pandemic. And looking at the recommendations from an asset model as opposed to a deficit model, so we can ensure that these lessons learned from communities of color as it relates to building vaccine confidence are ones that we can then share with the next pandemic. We may find that communities of color are actually more likely to access some medical, some things that would be really interesting to see. So we would just encourage you to think about an asset model. The other thing I wanted to bring up, Dr. Hildreth, you mentioned the importance of diversity, especially as it relates to underrepresented who are going into residency programs, and making sure that underrepresented individuals have access to all specialties. We completely agree, and thinking about the entire pipeline, both in elementary and medical school, as well as thinking about our centers of excellence in medical school. And I wanted to let you know that our Accreditation Council for Graduate Medical Education, as well as the AAMC, are working together on holistic review in graduate medical education, something that our medical schools oftentimes use, but our residency programs are beginning to use more, and would love to share more information about that. And finally, there were comments earlier about the training of physicians, ensuring that we are culturally humble, that we are thinking about cultural humility, and that we are addressing racism. Our Association of American Medical Colleges are developing diversity, equity, and inclusion competencies that will be released at the end of this year. If the committee is interested in an early draft, we're happy to send those along. I think that's important as we think about future pandemic preparedness and making sure that we have a workforce that is both diverse and culturally prepared for the next pandemic. Thank you.
Thank you, Dr. Fair. Next, we will hear from Dr. Vivian Johnson from the Parkland Health and Hospital System. Dr. Johnson, you have 3 minutes, and please proceed.
Thank you. Good afternoon, Dr. Nunez-Smith and members of the task force. First, I'd like to thank you for the important work that you've done. We appreciate the opportunity to share the work our system is actively doing to help underserved communities affected by COVID-19. Parkland provides care to indigent, uninsured, and underinsured residents of Dallas County, averaging more than 60,000 hospital discharges and 1 million outpatient visits annually. Parkland's payer mix is approximately 30% charity, 30% Medicaid, 20% Medicare, 10% self-pay, and 10% other. Parkland has provided care to nearly 46,000 COVID-positive patients to date. We also developed a comprehensive COVID vaccine outreach program, and we have administered more than 326,000 doses of vaccines so far. We were honored to have First Lady Jill Biden tour one of our school-based vaccination clinics. I'm here today to share Parkland's experience using health system pharmacists during the COVID-19 crisis, and to offer recommendations to improve not only vaccination rates, but also other services that are so desperately needed in medical underserved communities, such as HIV prophylaxis, diabetes management, and medications for opiate use disorder. What has worked well at Parkland, in addition to partnering with churches, we have attended community events and vaccinated people in the community. Also, public service announcements featuring Black and Hispanic community leaders were distributed through social media, along with local minority media interviews with Parkland providers, including pharmacists, physicians, and nurses. The federal government could positively impact health equity now in 3 ways. First, use the PrEP Act to authorize pharmacists to provide services as diabetes management nationwide, as you've done for COVID vaccination. Secondly, eliminate the X waiver, which restricts access to medications for opiate use disorder in our communities. Third, create a Medicare and Medicaid payment mechanism to support access to these services when they are offered or provided by pharmacists on healthcare teams. Pharmacists are trusted professions and uniquely positioned to offer expertise on vaccines and help close the gaps in care. In closing, I would like to leave you with 3 recommendations to improve vaccine acceptance. First, continue to partner with trusted individuals and make the vaccine readily available in the community. Second, use data geographically to target and prioritize vaccination efforts. And third, request the federal government to approve pharmacists to have provider status now to help improve patient outcomes and impact health equity. Parkland and ASHP urges the task force to draw on pharmacists' expertise as critical members of the healthcare team. Thank you for your consideration of our recommendations.
Thank you, Dr. Johnson. Next, we will hear from Dr. Cheryl Grills from the Loyola Marymount University. Dr. Grills, you have 3 minutes, and please proceed.
Thank you to the COVID-19 Health Equity Task Force for this opportunity to share a few comments with you today. Again, I'm Dr. Cheryl Grills, and for today's purposes, I'm representing, in partnership with the National Urban League, the National Alliance of Ethnic Psychological Associations for Racial and Ethnic Equity. The Alliance led a national research effort to inform the Congressional Tri-Caucus and the Native American Caucus, among others, about COVID's impact on communities of color. The Alliance is a partnership of several psychological associations, including the Asian American Psychological Association, the Association of Black Psychologists, of which I'm a past president, the National Latinx Psychological Association, the American Psychological Association, and the Indigenous Wellness Research Institute. Our COVID-19 Communities of Color Needs Assessment was conducted between December of 2020 and April of 2021, and it was designed specifically to fill the existing COVID-19 data gaps connected to missing or small samples of racial, ethnic, and other demographic groups, the lack of disaggregated federal, state, and local race-specific data, and the absence of community-informed, culturally nuanced insights and understanding of COVID's differential impact within and across racial groups. We too are seeing COVID as a syndemic, but we believe for communities of color, it is a syndemic on steroids. The findings that we have from our study provide a snapshot of COVID's impact, including the adverse outcomes related to physical health, mental health, finances, employment, business, education, gender differences in unpaid work, food insecurity, technology access, housing insecurity, vaccination intent and messaging, the impact on children, basic needs like utilities and Wi-Fi access, and the role of racial stress and discrimination. These findings also identify community use of culturally specific protective factors initiated by communities to mitigate COVID's adverse effects, as well as exposing a number of problems with Western research methodologies with communities of color and their many subpopulations. So we have shared a top lines statement document that gives you an overview of some of the major issues. And then separately, we will, within the next week or two, make available to you a full report that has a number of recommendations broken down by racial or ethnic groups, because one size does not fit all. And we have to do much better. Our communities are really, really, really struggling. Thank you.
Thank you, Dr. Grills. This concludes the public comment. Back to you, Madam Chair.
Thank you very much, Captain Wu. Thank you to everybody for public comment. Very, very impactful. At this time, we're going to return to our interim recommendations. We will take up each slate by subcommittee in the order in which they were presented. First, we'll start off with the Healthcare Access and Quality Subcommittee. Will somebody move that into consideration, please?
Move for approval.
Thank you. A second?
Second.
Thank you very much. Any further discussion? Okay, thank you. Seeing none, please indicate your support of the slate by signaling with your virtual hand, yay.
Virtual hand.
Thank you so much. Everybody, please give a moment for the contract to be able to tally.
The virtual.
You can only vote once. Thank you. Thank you so much. Thank you. Any names? You can take your hands down, please. Thank you. Any abstentions? All right, thank you. I vote yes, that motion carries. Okay, we'll turn next to the slate of recommendations put forth by Structural Drivers and Xenophobia Subcommittee, please.
So moved.
Thank you very much. Dr. Martinez, second.
Second.
Thank you very much. Any further discussion? Seeing none, we'll move to voting. Thank you. Please indicate, thank you, yays. Okay, 1 second. Thumbs up also works. Thank you very much. One moment for the contract. Okay, thank you very much. You can take your signal down. Any nays? Any abstentions? I vote yes, that carries. The third slate of interim recommendations, communications and collaborations subcommittee. Do I have a motion?
I move that we approve the slate.
Thank you so much, Mr. Watts. Second?
Second.
Thank you, Dr. Hildreth. Any further discussion? Thank you so much. Yays? Okay, one moment. Thank you so much. You may remove your signal. Any nays? Thank you. Any abstentions? Okay, I vote yes. That motion carries. And finally, we'll take up for consideration the recommendations put forth by the Data Analytics and Research Subcommittee. Do I have a motion?
So moved.
Thank you, Dr. Martinez. Second.
Second.
Thank you so much, Mr. Toronzo. Any further discussion? Okay, thank you. Seeing none. Yeas, please. Thank you. One moment. Just 1 moment. All right, thank you, everybody. You may remove your signal. Very good. Nays, abstentions. I vote yes, carries. Congratulations, task force. Another phenomenal slate of interim recommendations. Just phenomenal work. As always, a reminder for those who are joining us today that all the recommendations that are voted upon in these meetings are interim recommendations. They will be finalized and presented in a future meeting. We have come to the end of our 6th public-facing meeting. I want to just take a moment to say thank you. Coming off of the public comment, thank you to everyone for sharing and joining with us today. A special thanks, of course, to all of our subcommittee chairs, to each and every single task force member. Their recommendations, once again, thoughtful and actionable. Much appreciated. To our guest experts, thank you so much for your contributions here in the task force, but certainly in the work that you're doing and leading, as well as to those subject matter experts that have joined us throughout. Let me take a moment just, of course, to acknowledge the leadership and express gratitude to Dr. Okafor, who's our executive director. Thank you to Captain Wu, our DFO, to the entire federal staff team, and to the contractors who are invaluable as well. It takes so many people to support this work. The work is not easy, but so meaningful and so helpful. For today, thank you very much to our ASL interpreters as well. I think we can certainly reflect even now on the meeting we've had and know that the time demands a new post-pandemic reality. We've heard it over and over again. It's unacceptable for us to return to normal policies and practices and procedures. And so whatever that is, be it housing or nutrition, education, employment, healthcare, those are the same policies and practices that have failed too many. And when we think about minoritized, marginalized communities, those that are medically underserved and center on them, this is exactly what has contributed to their vulnerability in terms of the tragedies from COVID-19. So all of us have been called, I think, to continue in this work with great intention. For your awareness, there will not be a public-facing meeting in August. So to those who join us, please look out for the date and time of our next meeting, which will be provided in the meeting notice that's published in the Federal Register. The notice will also be posted on the task force website. For your interest and information, past recordings and minutes from prior task force meetings can also be found there on the website. So with that, thank you everyone for joining. Please be safe, look out for your neighbor. We are adjourned.
Mm-hmm.